We've been tracking for the last few days consistently a drop in the daily count of COVID. Now, the daily COVID count is an important indicator because it tells you how many new cases have been detected in the last 24 hours. This was the number that had dropped as low as 11 and 12,000 at the end of last year, and which had made us feel pretty complacent. It has even crossed 4.5 lakhs per day in the last few weeks, and in the last week has been dipping consistently. Now, in the yesterday's number, which came out this morning, was below the 3 lakh mark at around 2,80,000 for the first time in over 25 days since the 21st of April, and that is being looked at as a pretty big deal. But a few caveats here. First of all, testing is usually low on Sunday. We've seen that consistently month after month, week after week, so it could be the Sunday effect. Secondly, we've seen that fatality rates, that means number of deaths from COVID in a day, are still high, above 4,000. Even that can be explained away because the death count comes at a lag compared to positive case counts, but the TPR, or the test positivity rate, also continues to be fairly high at about 18%. So what do we make of these numbers? Are we making a turn for the better? Is the worst behind us, or are we simply not able to count the extent of the COVID spread because a lot of new cases are coming up in rural India where the testing might not be that high? To speak on some of these aspects, I'm joined this evening by Dr. Gangakhedkar, Fmr Head of Epidemiology at ICMR. Dr. Velumani, Chmn MD of Thyrocare, joins us today, as does Viren Shetty, ED and Group CEO of Narayana Health. Welcome to all of you, and thank you so much for speaking with us. Dr. Gangakhedkar, I'd like your view on the numbers first, because there are a lot of predictions. There's some modeling been done by Sutra as well, and we'll play out those comments and information for our viewers as well, that say that the worst is behind us and we should see an easing, say, in a couple of months of COVID cases. Are you convinced that this is us coming off the peak of the second wave at least?
So when we say that are we coming off the peak, we are coming off the peak if you look at those graphs. But essentially, when you look at those graphs, we perhaps don't pay attention to one fact, that it is too sharp a decline, which essentially means that most of the data, if it is coming only from urban area, in a large proportion, you might find a sharp drop that may be coming. India is a highly heterogeneous country. Now, even if it comes to the drivers of this particular outbreak, whether it is mobility, whether it is migration, whether it is population density, and then if you try, and also the healthcare infrastructure when it comes to testing or hospital infrastructure. Most often, when you want to validate that drop, one tends to say, are now beds available as the first indicator. But please remember that when you say availability of beds, it is essentially that you are talking of urban areas where the pressure on healthcare infrastructure was strong. But this time, the outbreak is also severe in rural areas, and therefore, as you rightly pointed out, that perhaps we may have to wait to see whether there is a decline, that is significant decline, which you can actually say now it is plateauing. Second thing which we must remember, that some of the states, just because of heterogeneity, they are still showing an increasing trend. If you look at Andhra Pradesh, Tamil Nadu, then Odisha, now these are the states where it is still increasing. Now, if you add up all that, if you look at the vulnerability with respect to the population density that exists, urban-rural population, which is, if you look at rural population, it's almost 3/4 of India tends to be living in rural areas as such. And you look at the certain states like UP, Bihar, and West Bengal, where the population density is also extremely high, rural-urban differential is far more compared to what you see as a national average. So we should not conclude quickly if we conclude that it is plateauing, perhaps as you rightly said, that complacency may creep in and it could still affect everything, all intervention measures across. So the best is we keep our guards at this juncture. We keep on looking for the evidence whether there is a true plateauing that may be reflected in the graphs as of now, and try to ensure that healthcare infrastructure in the rural areas and the strategies to deliver healthcare to people living in rural area is somehow strengthened.
Yeah, Viren, here is where it's important to get a voice and a view from what's happening on ground. Are you seeing more space in your hospitals? Are you seeing it easier to get hospital beds, or is there still the same extent of pressure on medical infrastructure? What are you observing?
I wouldn't say the same extent of pressure as before. Whereas previously I would get 100 phone calls a day, now it's down to around 20. But it is still 20 phone calls that I'm not able to accommodate. So it's still pretty bad, I would say. I definitely concur with Dr. Raman's observation. This is not the time to put our guard down, not the time to celebrate any sort of premature victory. It's still very much out there. The virus is spreading. We've noticed a huge uptick in the cases coming to our hospitals in small towns across Karnataka. So we're still very much not out of the woods yet.
A bit more, Viren, about what you're seeing in, when you say small towns across Karnataka, because this is the story which is completely unseen right now. There's just bits and pieces coming in on what is really happening in rural India. Is medical infrastructure reaching there? And even outside the large cities, is medical infrastructure tapped out in those places? Are people even aware that if they are seeing certain symptoms, they need to get a COVID test and they need to seek medical care in that direction?
I would say the awareness is definitely there. It's not like just because they live in a small town, they don't have access to the news. They've all seen the horror stories of what happens in the big towns. And I wouldn't say it's happening to the same extent, just because the population may not be as densely packed as in large cities. But to give the example of Karnataka, our main hospital is in Bangalore, but we have hospitals in Mysore, Shimoga, Bellary, and Dharwad. And we're seeing that while previously there would only be 5 or 10 patients in the COVID ward, now it's closer to 50 to 60. And it doesn't take a lot, because in small towns, there really isn't as much infrastructure as the big towns, neither for the public hospitals nor for us. Even our hospitals in small towns are 1/10 the size of what we have in the bigger cities. So it doesn't take a lot for it to swing the barrier. But having said that, there is also a big difference in the population of the two areas. So even last time around, what we noticed, most rural areas were pretty unaffected. Over here, they will be affected. My guess is it may not be to the same extent, but that is absolutely of no solace to a person who cannot get his family member admitted to a hospital. Regardless of where you live, that is a crime in any circumstance. And so we have to do more. Taking this as a great example of how we have to improve the healthcare system.
That's the big question when it comes to the overall numbers. And Dr. Gangakhedkar, I just want you to take us through underlying this. And we just need to look at the data a little carefully. So one factor that everyone looks at is the daily cases, the daily COVID count in the last 24 hours. But what about the fatality rates? And what about the concerns that those could be underreported?
There is always a possibility of underreporting, especially if you think in terms of the access to even diagnostic tests. That perhaps would be a major differential between urban and rural areas. So even attribution of death is likely to be extremely challenging at this juncture. No, so essentially, I would say that there would be some of the gaps in data. Now we need to wait and look for solid evidences which can plug this gap in data to try and give us a picture whether it's actually plateauing at this point in time. I would rather think the way it has come down sharply perhaps it may not be a complete reflection that it is plateauing, because it has come within a very short period of time. It's coming down and reaching a peak as if you have gone up the hill and then suddenly you are coming down. This possibly can also happen if it is a new variant, which is rapidly transmissible. It tends to infect large number of people at one point in time. So clusters of cases could come up and then it suddenly starts dropping down. But that kind of picture is difficult to explain because the proportion of variants which so far have been talked about continues to be small enough in a given population. So it would be also a speculative kind of a treatment consideration to my mind.
Dr. Velumani, what is your observation as far as the numbers are concerned and testing? So some argue that we are seeing a drop in daily numbers because testing is also reducing when in fact it should be increasing. Is that a fair enough observation in your view?
Dr. Gangakhedkar said, it's a very heterogeneous country. Unless you have a testing equity, which is per lakh population from different states, urban, rural mix, it's very difficult to conclude that we have correct numbers in hand. It could be a gap, small gap. It could be even a very big gap. Having said that, the rapid antigen test arrival and priority for that, and the reduction in number of people traveling in air and because of cases going down, then festivals, holidays in punctuating in between, all could be reasons to see a low number of testing also. But having said that, Mumbai has got 12% positive, Delhi has got around 17-18% positive, still Goa has got 45% positive. So what contributes for this numbers to come down? Is it the biased city population? Very difficult to conclude. But one thing is certain, we have not breached 400,000 and continue to grow. We have come back to 300,000. Whether it is really 300,000 or still 400,000 is very big question. But I must tell you that it's too early for us to relax. We can't get into the similar situation what happened after the first wave. In my personal opinion, we must analyze what is the percentage of rapid antigen test-based results. Is that influencing your percentage positivity in Delhi and Mumbai? That has to be studied, and I can't very confidently talk that, yes, worst is behind us.
The other question is, and I want to focus a bit on what we spoke earlier, the fact is that COVID is now spreading also out of the big urban centers, which have been the hub and the epicenters of this so far. So Viren, let me just come back to you on a point that you were making earlier, that it's unfair that someone doesn't have access to medical infrastructure no matter where they live. You called it a crime, and rightly so. So what really can be done so that we don't find ourselves unprepared as COVID starts breaking into village after village or smaller towns as well, which lack that medical healthcare completely?
In a short period of time, not much can be done. I would guess maybe, okay, so the large cities are drowning in resources right now. It could be that there's an excess of oxygen cylinders, concentrators, excess of medicine. Definitely, large groups like us will start diverting stock if we start to feel that the requirement in the large cities isn't as much. A large central coordinating agency like the government will definitely start making moves in that direction. People can travel. We have an excellent transport connectivity network, and it's not that people from small towns weren't going to big towns for treatment. They would, absolutely. And so if we do not put any blocks in the borders and prevent people from getting treatment where they are most likely to be treated, that can definitely help alleviate the short-term pain. But all of this is bandage on a bullet wound. Long term, we have to do all the things that doctors across the country have been saying, that public policy experts have been saying. We have to get the government more involved. We have to spend more money. We have to invest a lot more in public healthcare. We have to train a huge number of doctors more, huge number of nurses more. These are all the things that will definitely help us, because it seems now that this pandemic is what they're calling endemic, which means it will always be with us. It will get successfully weaker, but the pandemic is going to be with us for a long time. And the healthcare infrastructure we put up now will not be wasted. We have the chance to build the healthiest country on earth because we have the largest number of people, which is the only raw material you need to build a world-class health system. So we have whatever it takes to be able to tackle this permanently and show to the world that healthcare and the quality of healthcare is completely independent of the affluence of the nation. So this can be the greatest opportunity this industry has faced, and I don't see any reason why we cannot succeed in that.
And we should not waste more time. We could have built up a bit of this infrastructure over the last 1 year, over the last 15 months. Let's not make that mistake again and assume that, just because some of these cases are possibly not being counted, that they do not exist. Dr. Gangakhedkar, I want to talk to you about test positivity rate and the kind of differentiation we've been seeing in different parts of the country. And we've been seeing this as a trend. It's almost as if the hub of the virus moves from area to area. So if it was in Maharashtra a few months ago, then Karnataka started being impacted, then Uttar Pradesh reports have come, now Goa seems to be in the grips of it. Why are we seeing that pattern? And is it, following a pattern of surge in cases, then a harsher lockdown, and then a reduction in cases? Are we sort of stuck in that vicious cycle?
What I would say is the major differences that we are generally seeing could also be a reflection of when the outbreak intensified in those particular areas. Now, in some places, it may have had started little late, and therefore they would have higher positivity rate compared to places where it is likely to be on a decline. The second issue which we also need to remember, that even the testing facilities were getting swamped in the urban areas, and therefore there were delays in getting the test results as well. So essentially what we are seeing as of now in terms of what does that actually test positivity rate would mean essentially to us. This third thing which we have to understand is the uptake depends on the individual. No, the person who's going to approach and take that particular test, and an uptake is also influenced by access to testing, and therefore the access related issues, healthcare infrastructure will also play upon. You might find there could be a discordance in people getting hospitalized and the test positivity rate. People could get admitted without the diagnosis as well. No, that is something which will perhaps tell us that merely relying on test positivity rate and assuming that it will be uniform across would not be a fair thing. But at the same time, one bottom line that we should have is we should aim at bringing that test positivity rate to 5%. But at that juncture, as Dr. Velumani did point out, that the proportion that is actually getting tested by rapid antigen test has to be in check in order to make good inferences out of it, whether it is truly declining. And the last thing which I would say, there is a perception that all of us have actually created. The more the number of cases, the worse is the outbreak being handled. And I think it is time we have to tell people that if a government, it should not be treated as failure of the government. If there are more number of cases that have been found there, that means they are testing more, they are diagnosing more individuals and ensuring that they will be isolated. The contacts would also be isolated and tested, whatever the situation could be, and some of them may actually receive care if they need to. So that should not be equated. A large number of cases should not be equated with poor governance, and that message has to go very.
I find governments are usually pretty thick-skinned, Dr. Gangakhedkar. about criticism, and the real criticism is, you're right, just because there are a large number of cases, that doesn't mean that it should be criticized, but large number of cases could mean proportionally larger number of deaths. The true failure and the true criticism comes when people don't have access to medical infrastructure, when you have desperate SOS messages for beds, oxygen, medication, and plasma donors and things like that. That is a failure of governance, which I don't think anyone can shy away from. And that is the concern with the large number of cases, that if you have a large number of cases, is it going to, in effect, lead to a shortage of medical infrastructure? Dr. Velumani, I want to come to you quickly on a point of testing and how we can ensure that large parts of India don't become sort of a dark room where we just don't know what's going on, where we don't know if there is COVID, whether deaths are happening due to COVID, and then you just have anecdotes coming in that so many people were cremated, or so many people lined up at a local health facility. So how can we ensure that testing is spread wider? Do we have the capability of doing that right now?
We have capability. In March 2020, we had only a capability of doing 10,000 tests a day. Today, we have got a capability to do 25 lakh tests a day, which means within a year, the scaling up has gone very, very high. You will see another 6 months' time, if this pressure persists, capacity will go up. But again, we are only testing the top of the pyramid, top half of the pyramid, bottom half of the pyramid. They don't have money to go to hospital. They don't have money to wait, stand in a queue. Oh God, I'm from a village and I still have roots from village. In villages, families have died. They never went to the hospital because all the hospital close by are not capable enough and they are all full. So it is very, very sad to note that we can't test all. They don't have money to test. Even if it is tested only 300 rupees, they don't have money. Even if you tested 100 rupees, they don't have money. So it is very, very worrying that bottom half
Why shouldn't testing be free right now? Dr. Velumani, you've raised a very important point. Why shouldn't testing be free right now? I'm not saying that the companies pay for it, but why cannot the state government, the local administration ensure that there is a free testing facility? For those who can't afford it, shouldn't that be the case by now?
A single day 400 crore liquor sales is happening in Tamil Nadu, one state. So if you notice it, it's very, very disheartening to know testing government cannot do, vaccine government cannot give free. It's gone. Virus only can save us. No one else will be saving us.
That's on that fairly dark note, I will wrap at this point. The big message coming in that yes, the cases on paper are coming down, but we will have to wait and watch and see for how long, it can really extend. Can we sustain this momentum? And it should not come at the cost of underreporting of what is going on, and especially cases as they grow in rural India. I want to thank all of you for joining us on that discussion and play out for you an excerpt of this interesting conversation my colleague Ruchi Bhatia had today with Mahendra Agarwal, who's an IIT Kanpur professor and part of the 3-member team which has come up with the Sutra model. Now, this model is being used by the central government as well as one of its resources to decide policy actions, and according to Professor Agarwal, he claims that we will be seeing daily cases dropping shortly.